Welcome to Grand Rounds. My name's Tom Fardon. I'm the chair of Grand Rounds. It's a pleasure to see you all today. And it's a great pleasure to be able to introduce a colleague and friend, I suppose.
I'll confirm that.
That's nice, good. And that's Dave Connell, who's here. He tells me he's just here as the compere of his dynamic crack team that he's got behind him. And we have a variety of different people who are going to speak from infectious diseases, respiratory medicine, public health, pharmacy, and who knows who else might turn up to talk a little bit about the consumption, the TB. When Dave came here 2 years ago from London, he came as a card-carrying tuberculosis doctor, and I remember speaking to him when you came to visit and said, "Oh, there's no TB in Tayside, you've got to find something else to be interested in because we just don't see much TB." He said, crestfallen, well, never mind. But if you look for it, you find it, and the more you look, the more you find. And what Dave's been able to do in coordination with the rest of this team is to make a TB MDT, because when you find it, you need to treat it. And that's what Dave's going to talk to us about. Now, because of the vagaries of the electronic system, I'm going to have to accidentally, on purpose, just get rid of Perth. There they go. Because he's got some sound in on his videos and it doesn't work if you're connected to Perth. I don't know why. But it'll all be recorded and you can watch this on our YouTube channel if you're in Perth. Okay, without further ado, Dave and his team, TB in Tayside.
Thanks very much, Tom. So tuberculosis in Tayside towards elimination now. I'm kind of obsessed with tuberculosis, and hopefully that will come across a bit. And this is what TB is. This is a scanning electron microscope of the rod-shaped bacillus infecting a macrophage, or a few of the bacilli infecting a macrophage. And this is what TB does. It is an obligate intracellular pathogen. It only lives inside cells, inside human cells, or some cows and badgers and so on. About 50,000 years ago, there were some free-living environmental mycobacteria, and something happened and they changed, and they only became able to live within human cells. And ever since that moment, TB's had a huge impact on us as humans, and we've had a huge impact on it. And in fact, the genetic architecture of both the human and the bug are very similar in terms of their worldwide global structure, because we've had such an influence on it and it on us. And this is what it does. It causes lung disease, and this is reactivation in the right upper lobe, and the arrow points to where the original infection at the gone focus was. It also does this. It spreads within the bloodstream to cause miliary TB. Here it's in the lung, but it will be in the liver, it will be everywhere. It can also cause disease within the brain. It causes disease within the skin, within the eye, within the bone marrow. It causes disease anywhere. It's well adapted to living within humans. Now, by the 19th century, approximately a third of Londoners were dying of TB. And because of that, it had a huge impact upon the culture of Western Europe at that time. So who's this? Anyone? It's Anne Hathaway. But what character is Anne Hathaway here? No one watches films anymore, right? She's Fantine in Les Mis, right? And she falls into a bad way, has her hair cut off, her teeth pulled out, and she dies of TB. And there was this kind of sense of the heroic death of consumption. It's not really heroic to die of TB, of course. It's terrible. But people like Keats had TB, and this led to the kind of sense of the romantic ideal of someone dying of consumption. More recently, George Orwell was one of the first people in the UK to get streptomycin at Hairmars Hospital in East Kilbride. He didn't survive his TB, though. He wrote in 1984 as he was dying of TB on the island of Jura. But I will argue now that these are not the greatest works of art inspired by TB. In fact, the greatest work of art inspired by TB, or as a result of TB, is not in the field of opera or literature, but it's a fellow streptomycin recipient, Bill McLaren. So Bill had TB, he was on the verge of a Scotland cap. He got struck down with TB and was sent to a sanatorium. He couldn't play rugby anymore, but what he could do was lie in his bed and commentate on table tennis matches. And from that became born the greatest work of art in the modern canon, which is this. Apologies to the English. Okay.
That's quite an advantage to the Scots, because that looked like quite a useful ball for England. Picked up by Jeffrey. Jeffrey to Armstrong. Armstrong, nice work to Gavin Hastings. Gavin Hastings with the kick through. On goal Stanger. Stanger could be there. Fact, it's a try.
Okay, gratuitous. Had to do it. Thanks to Tom for the IT support. Okay, so...
There's now 4 people in person who want to phone back in again. So, I can't do it, they have to do it. Oh, you carry on, but I made it back to...
Okay, fine. So, this is a map of TB spreading around the world with human beings in the 50,000 BC. We found TB remains in the Middle East. So it's the oldest respiratory pathogen which is now ideally adapted to parasitising human cells. So briefly, the TB life cycle. Someone's got TB, this person's got it in the right upper lobe, they cough into a household and 50% of the house get infected with TB. They're not unwell, but they've got TB lying dormant within their lungs. Those people are yellow, okay? So half are yellow, half are green. Some of those yellow people might clear TB themselves completely. That's a controversial topic. But let's assume that most don't. Most people will remain infected with TB, we think, for the rest of their lives. A small proportion will then become unwell themselves. We think up to 5% within the first couple of years, and then up to 5% for the rest of their lives. Okay, and that's active TB. These people are unwell. They then, if they've got it in their lungs, cough it back up and infect more people. So how do we treat TB? If we find people with what we call latent TB at this dormant stage, we give them 3 months of treatment. It's still a long time to treat someone. They get 2 drugs. If someone's unwell with TB, with active TB, they need at least 6 months of treatment with between 2 and 4 drugs, depending on the stage of their treatment. Because of this bug, which is well adapted to living within humans and has spread all over the world, and which is difficult to treat, there are approximately 10 million cases of TB a year still, and over 1 million deaths a year. So it's an ongoing global epidemic. Because of this, the WHO has said we need to do something very serious about this. We need to get rid of TB completely by 2035. Okay? That's a huge thing to try and do, because you've got to not just treat the 10 million cases a year, you've got to treat other people who are dormantly infected, or if not treat them, prevent them getting sick later on. And at the moment, we're not on schedule for doing it. So our current global trend is a decrease in TB cases by about a percentage point a year. We need to be up to 10% a year globally if we want to meet this WHO goal of TB elimination. And that blue line at the bottom is when you start to enter what's known as low incidence, so 10 cases per 100,000. And that is what Scotland entered about the year 2010. So we're now officially a low incident country. So you can see here, in around 2010, the blue line just was going up and starts to fall again, and that's we're falling into the low incidence area. What we need to do in Scotland, if we want to meet these WHO goals, is get to the red line, which is 1 case per 100,000. Okay, so we're not there yet, and in fact the modelling suggests that we're not going to get there, even with our current rates of decrease. This is where TB is within Scotland. So we're here, Tayside. We've got 4.3 cases per 100,000, which is similar to Grampian, not dissimilar to Lothian, which is 4.9, but Glasgow leads the way at around 10 cases per 100,000. So the majority of cases of TB are in Glasgow, but certainly Tayside, Lothian and Grampian have a not insignificant number of cases. These data are from England, just showing where we are in terms of the curve and where we need to get to. And what they're saying basically is if we carry on with status quo down this red line, we won't meet, even in a highly wealthy country, which is already a low incidence country for TB, we won't meet the WHO goals if we carry on doing what we're doing now. We have to achieve an annual decrease of almost 25% a year in TB if we want to be able to eliminate TB from the United Kingdom, which you'd think we ought to be able to do. So if one looks at the data from the health boards in Scotland which have the most TB, so Forth Valley, Grampian, Glasgow, can't remember what HG is now, Highlands and Grampian, Lanarkshire, Lothian and Tayside, we've all seen falls in the last 5 or 6 years in terms of TB. Glasgow has seen an increase in the last 3 years, but Tayside hasn't seen any fall in the number of cases of TB in the last 5 or 6 years. And in fact, this was noted upon in this year's TB report for Scotland, that both Glasgow and Tayside have seen a recent, in the last 3 years, increase in the number of TB cases, which is a concern if we want to try and eliminate TB. So the question is, why are we not seeing falls in TB cases in Tayside and in Glasgow? Could we be better? What does it mean for eliminating TB across Scotland and the UK? If our goal is to eliminate TB, to get to that dotted red line of 1 case per 100,000, are we going to be able to do it if we can't even see a fall in cases in a locality like Tayside? and what does a pre-elimination phase TB society appear like. And what we're going to do now is just talk through some TB cases with colleagues from ID, pharmacy, and microbiology to show you about the challenges of what managing TB is like nowadays. I think 30 years ago we probably dealt with all the easy cases, and what we may be left with now is a rump of difficult set of TB cases. So before we get to that, we need to think who gets TB, and the short answer is people who've met people with TB. Okay, so these are very old data showing that if you observe people following contact with TB, the highest rates of TB are in the first 5 years, and then the rates fall. So there's something about meeting TB recently that means you're likely to then get TB yourself. What does this look like in Tayside? So an example. So we've got a patient Y. So a friend of this guy, a friend of Y, had TB about 3 or 4 years ago. Now, they didn't live together, but they lived in a little group of friends who used to drink together in a small flat. So we'll call that a household. A number of these people were screened, including Y, and Y had a positive skin test, which means that he was infected with TB. He himself did not want any preventative treatment at this stage. Okay? 3 years later, he gets a cough for 8 weeks. By this point, all his buddies in this group of drinkers have left or died, and he's by himself, and he loses about 20% of his body weight over about 8 to 10 weeks. He can't leave the house until he basically gets found by his GP cachectic with an albumin of 13, at which point he gets an X-ray and we get a phone call. We get a CT, and here we see the typical appearances of TB. So we've got a cavity in the upper lobe with surrounding tree and bud, endobronchial infection and nodularity, and there's lots of it. And we put him in TB treatment, and quite quickly he actually gets worse, to the point at which we think he might not survive. He's got disease in all lobes of his lung, he's hypoxic, he's extremely underweight. So we found that this man had the same bug that his pal had five years ago. It's isoniazid resistant, which means we need to treat him for at least 10 months, probably a year at least. He was deteriorating on therapy, effectively homeless and malnourished, withdrawing from alcohol, and very isolated. But with the work of some of the people you'll hear from this afternoon, 3 months on Ward 42 with therapeutic drug monitoring, rehousing, a year of therapy given by a pharmacist in the community face-to-face, initially daily and then 3 times a week, we managed to clear his lung up, as you can see, increase his weight to up by 25%. I think those of us who met this patient saw kind of a new human being emerge from a man who was isolated in Ward 42, who ended up turning up telling jokes with a new set of clothes and changing his life, really. His albumin went from 12 or 13, eventually after 4 months into the normal range. But he is left with quite significant lung damage, and that may be something that is a problem for him in the future. And we know that from James Chalmers' work that one of the biggest causes of bronchiectasis in India is TB. One wonders whether this patient will have a similar problem. So he just emphasises this is TB in Tayside in 2019. It's highly complex. This man needs a prolonged admission with quite significant pharmacological problems and social problems. When we saw this, Ben Warner, one of our registrars, looked back at our cases before the data came through from the government, and we saw that our cases of TB had been going up over the previous 18 months. So this, plus the fact that we're seeing these more complex cases, led us to instigate a more regular TB MDT. We'd met before then less frequently, so we decided to try and meet more often, get more people together to try and improve management of these cases. So you can see the people around the table and the kind of things we'd focus on. And at the moment, we're meeting around 6 weekly. And Ali Wilson's going to talk a bit about what that is.
Hello. So as Dave says, I'm Ali. I'm one of the ID registrars, and my role in TB in Tayside was to try and create something that makes the care more cohesive and streamlined amongst the teams that are involved. So we created a pathway last year. We implemented it this year. As Dave said, a bit of background, the care of patients with TB in Tayside is shared medically between 2 teams, between infectious disease and with respiratory, but also includes lots of other teams that are involved, so antimicrobial pharmacy teams, the microbiology department, health protection, and infection and prevention control team. So because there are so many people involved in different medical teams looking after these patients, we wanted to make sure that the care that people were receiving was standardised, was the same, and to have some sort of baseline to go off. The areas particularly we wanted to focus on was communication, not only between ourselves and the MDT, but between primary care and also other teams that might be involved with the patient. So we wanted to make sure that if someone in Tayside had TB and was started on treatment, if they got admitted to A&E, if they got admitted to AMU, they'd be able to see what the diagnosis was, what they were started on, how long roughly the duration was. We also wanted to identify any areas... Perth.
2 secs whilst I get the... Can you hear us, Perth? The waving?
Yes, we can hear you.
We still love you, I'm sorry.
Okay. So as I was saying, the main areas we wanted to improve on was communication between the MDT and other primary cares and other receiving units. We want to identify any issues with continuity of care and create solutions that basically standardise the care of all patients with TB in Tayside. So we did an initial audit, and with the help of Rose Jordan, one of the IMT doctors, we looked at our local practice of identifying and managing TB in Tayside. We did an initial audit of which included 26 patients, which was between January 2017 and July 2018. This in itself was a bit of a challenge because we realised that there were different patient lists amongst different teams. Infectious diseases had a list of patients, microbiology, the antimicrobial pharmacy team and the health protection team all had different lists of different patients that were under the care. Out of the 26 patients, you can see it's fairly evenly divided, 58% under the care of ID and 42% under the care of respiratory. The areas we wanted to focus on and what we were doing was mainly on communication of the diagnosis, the treatment regimes and duration, as well as a baseline screening test that we wanted to standardise in Tayside. We collected data mainly from letters on Clinical Portal because that's where our main communication was going to focus on, and ideally it was going to be the initial clinic letter that was put on there that we wanted to make sure had all the correct information on, as well as ECS in terms of what drug regime they were on. So the initial letter documentation, so about 54% had a documented start date of when treatment was started. This is important because it's a key performance indicator of diagnosis to treatment within 7 days, and to be able to show that we're meeting that, we wanted that documented clearly. 92% had a documented treatment regime. 73 had a planned duration. We understand this isn't always going to be straightforward if they're not pulmonary. It can be a little bit complicated in terms of what is the planned duration if there's drug resistance, but an estimate of what duration would have been suffice. An 88.4 had a diagnosis, and we were very picky in terms of what the diagnosis was documented as. We didn't just want TB, we wanted the site as well. So if someone got admitted and they had pulmonary TB and they just started treatment, what infection control measures would someone have to take if they came in as opposed to cutaneous TB? So we wanted to differentiate that, so that's why we're quite picky. We also looked at baseline BBV testing, so particularly HIV and TB go hand in hand. If you have HIV, you're 20 times more likely to develop tuberculosis as opposed to someone who didn't have HIV, so we really need to be on top of our game in getting that tested. And hepatitis B and hepatitis C based on NICE guidelines, but also thinking about hepatotoxicity with TB drugs. We collected all the data from ICE and what was available, so under half had a full BBV screen, 19% had no baseline BBV testing, which was unfortunate, and then we had 35% that was incomplete where they had an HIV but no hepatitis screen. Baseline testing in terms of visual checks, so this is only where applicable depending on what medication they were started on, but 19% of those that needed a visual check had it documented. And that's not to say they didn't have visual checks done, it just wasn't documented. So if someone came in with a change in their vision, we need to be easily see what their vision was at baseline. And baseline bloods, we were fairly straightforward. We just wanted a full blood count, U&Es and liver function test, and about 80% managed to get that. So we sat down and developed and implemented the Tayside TB pathway. As I said, this was to create a more cohesive and streamlined approach to TB care whilst involving all members of the MDT. We didn't want everyone contacted all at the same time, so we wanted to create a centralised hub where we could target information to the teams as relevant. We based it sort of on a referral system that came to one place, and then we focused on transferring that information out. If new referrals came in and weren't allocated to either respiratory or ID, we would make sure there was an allocated team and an allocated consultant, so that if any issues came up, everyone knew who to contact rather than just contacting everyone. This is where you'll find it. So this is on formulary under respiratory. And we created a TB pathway and also the TB prescribing guidance, which Kirstine will talk about a bit later on. It's based to be very, very simple. So any new diagnosis, any likely diagnosis, anyone you're concerned about, or if you're about to start treatment, we want to know about it. As much information as we can get, particularly looking at weight, renal, liver impairment. And if you know what drug regime they're going on, it would be helpful. That information then gets emailed to ID, where I check it, also gets emailed to Dave, and then we forward that information on as appropriate to microbiology, infection prevention and control if they're inpatients, the health protection team, antimicrobial pharmacists. It also prompts us to make sure they're put onto a central TB list so they all get discussed at a TB-MDT. And then the responsible clinician will be prompted, if needs be, to do baseline testing as well as signing the standard prescription charts. We also put information about the key performance indicator about diagnosis of treatment within 7 days and some prompts of what we want from baseline testing. So we then looked to see if that's made any difference. So we've started it in July and we've just taken some data now. So we've had 13 patients that have been referred with suspected pulmonary TB. Again, the split's fairly even, 46%, 6 patients to ID and 7 patients to respiratory. And 4 out of these 13 have been confirmed to have MTB infection. So I realise that it's 4 patients versus 26, so it's a little bit skewed. But we're currently sitting at 100% for documentation in terms of what's on the clinical portal letter, which is excellent, and we'd like to maintain this. We're sitting at 100% in terms of our BBV testing for those 4 patients, but also we've started to see an increase in the BBV screen just done at baseline for all referrals that were made, which is important. Documentation of the baseline testing. So we're sitting at 50% for visual checks, and we have gone back and checked the other 2 have had visual checks done. It's just about getting that documented on the letter. And 100% for baseline bloods. So an improvement all round, albeit with smaller numbers at the moment. So we have seen some success with the use of the pathway. Obviously, we're going to continue to audit and improve. We see the benefits is that we can almost micromanage the management and the care that's going on for these patients. And it allows someone to oversee their care, and we think this might be beneficial for a TB specialist nurse, which our service doesn't currently have, but for what might be beneficial. And the upcoming plans, we're going to try and maximise the efficiency of the service as possible. So looking into times from initial referral, times of sampling being requested, received and reported, and also when they're reviewed by a specialist clinician. As well as the Tayside TB pathway, we've included some monitoring advice based on NICE guidelines, but also locally agreed in terms of what we'd like to do if their liver function needs more monitoring closely, or key checks at 2 months. A reminder about communication with the community and updating ECS with what medications they're on, which is important. We've also created a dictation template which goes through all of the checks that we want and prompts people to do them and document them on the letter. We've a locally agreed drug-induced hepatitis and reintroduction regime, as well as the NICE guidelines for steroid regime and CNS TB. And then we've got the standard and continuation prescription charts. And talking about prescriptions, Kirstine's going to talk about the TB prescribing guidance.
Hi, so I'm Kirstine. I'm one of the antimicrobial pharmacists, and I work with the HIV team as well. So for a long time I've dealt with the TB patients for ID, but I've just really become involved through the MDT for the respiratory patients as well. So as Ali says, this is where the guidance is sitting. She's talked about the pathway, but we also have this prescribing guidance as well, really just to standardise what we're doing, because there were some kind of slight differences between the teams, and pharmacists really hate that kind of thing. We like people to do the same thing. So we've done these standard prescription sheets as well, just to help the prescribers so they don't have to look up lots of different things, especially when we're using combination products, because that will be weight-based. We have had some very significant drug shortages lately, so just trying to liaise with the teams as well about how we're going to manage that. Often we have to give separate tablets, which is obviously quite challenging for some of the patients that we're treating. I guess as a pharmacist, interactions are a big thing, especially having a background in HIV as well. So when you've got a drug like rifampicin playing in, there are some key interactions to think about. You can see it induces lots of different things. Actually, it also inhibits one of the transporters as well. Isoniazid is an inhibitor, but when you have rifampicin in it at the same time, rifampicin will win that interaction competition. That's why it's really important to have the medicines on the ECS, just so that if primary care are prescribing anything new, hopefully an interaction will flag up as well. And that's important to remember for the latent TB patients who also get rifampicin and isoniazid. So just some kind of common ones that we've come across while we've been doing the MDT. I think 3 patients have had implants and have been asked by various people, is that safe to use with rifampicin? Well, the answer is no, it's not, unfortunately. They will have to use barrier contraception, and for 4 weeks after the rifampicin is stopped as well, because it's such a potent enzyme inducer. So the only safe methods of contraception are barrier contraception, depots, or IUDs. Statins have really weird interactions, and I have to say I always check it every time. You have to withhold things and start things and change the times of day. Diabetes, we just need to consider drug interactions, but also that ISO can cause some hyperglycemia. And for not everything is rifampicin induction, so last week actually we had a rifampicin inhibition interaction where it inhibits OAT in the kidney and increases the levels of certain drugs like the valsartan, the Entresto combination there. So it's one of those drugs that you should always check with everything. Okay.
Thanks, Christine. So someone actually said to me recently, you should as a physician, you should never prescribe rifampicin without asking a pharmacist first, and I think that's true. One of the problems with implants or with contraception is what you don't want is to treat someone's TB successfully and then bring in a baby at the final appointment. It's embarrassing. So the TB framework for Scotland influenced some of what we have tried to do with the pathway, because it sets us goals on what we're meant to do. Unfortunately, some of the goals have been given to us without any expectation of there being any money to do it, which is a challenge for us. But one of the key things we have to do is contact tracing. So TB is an infectious disease, as I said at the beginning. If you cough up bacilli, 50% of people around you will then become infected, and 5% of them will then become sick too. So if we can identify those people who've been infected and treat them, then that's one of the ways that we're likely to be able to eliminate TB. So one of the things that the MDT does, as well as managing the pathway, is to manage things like advanced contact tracing. An example of this is patient Z. So this is a 43-year-old butcher from Perthshire, a Caucasian man. The pretest probability for TB in him is extremely low. He had cough and weight loss, so because of that he was referred to the lung cancer clinic. He'd been unwell for some time. Everyone assumed he was just getting recurrent chest infections. He had these areas of necrosis within his chest, which could well have been cancer, but also quite a lot of consolidation in the upper lobe, which is always a concern for TB. So he went on to have a bronchoscopy, and he did have TB. So this is a man that you think, why on earth has he got tuberculosis? He doesn't fit the normal stereotype or the epidemiological stereotype of someone who has TB. But if you take a history, he says his friend had TB 6 years ago, and he hadn't been contact traced at that time. Not long afterwards, his friend's mother then came to our clinic with a cough. And the question is, what's the link between the original guy, our butcher, and the mother? And our friends from Public Health are going to talk about that now. So I think Margaret Ramsey, who is a specialist nurse in health protection, is going to start. Or is Danny going to start? No, Margaret's going to start. And then Danny Chandler, consultant in public health medicine. I should say, we said we don't have a TB nurse, because Margaret Ramsey isn't officially a TB nurse, but basically she is a TB nurse. She does so much.
Hi. Hi, I'm Margaret, and this is Danny Chandler.
Danny Chandler, consultant in public health. So Margaret's going to talk first, and then I'm going to just have a very short window to give a couple of slides to wrap up the themes that we want to cover, and then we'll hand back over to Dave. So on to Margaret.
Okay, so following on from what Dr. Connell was mentioning there, we, just to give an example, we had a notification from a GP to health protection regarding a lady, 65-year-old lady with an abnormal chest x-ray, and the GP was seeking advice. This lady had a 3-month history of a productive cough, and she had unexplained weight loss, night sweats and fatigue. We took that history and we advised that we would speak to respiratory regarding that, but we also advised the GP at that point, because we didn't have the pathway set up, to make a referral to the respiratory team, and we asked the GP to submit sputum samples as well. Interestingly, the GP also mentioned that this lady's son had been treated for TB in the past. He didn't know the son's name, and but that was obviously important information to get. So we shared that information with our wider team, and the chest x-ray was reviewed, and they instantly referred the person for a CT. So following on from that, from our perspective, we have a very well-informed admin colleague, Eleanor, who has a really good memory and has a database set up for historical cases and contacts. She then went searching to find out who this individual might be. This person was identified, and it was this lady's son. He was a sputum smear positive case from 2011. Now, in 2011, the guidance that we were using at that point indicated that anybody older than 35 or older should only have a chest x-ray. Otherwise, if that chest x-ray was okay, they were then discharged. So this lady fitted into this criteria. So her chest x-ray in 2011 was satisfactory, and she was discharged from the clinic, given information about TB signs and symptoms, and off she went. So from all that information, we then went back and had a look. We were able to identify that actually there were 12 cases that were linked by MyRU. So that gives tells you what MyRU stands for, because I have to look it up every time. And there were 2 cases linked in recent years to the son of this new case. So we discussed this historical cluster within our MDT meetings, and the decision at that point was made to go back and review the contacts of the gentleman from 2011. The reason being, obviously, we had the current lady, and we had another case that was identified in 2017, so we thought, what is going on with this cluster? Did he was he of high infectivity that we should be concerned about? So we went back and had a look at that. And as I previously said, the guidance at that point recommended that this lady only had a chest x-ray. However, Scotland have now adopted the new NICE guidance, which was implemented in 2016. So had that new guidance been in place when she was identified in 2011, she would now have a MON2 test, which might have identified that she was latent TB, and maybe we would have then treated her differently. So from the MyRU, we discussed the whole genome sequencing, which isn't currently routinely being offered within Scotland, however it is in England. We asked at the reference lab if this could be carried out on this cluster of cases, and this is what they came back with. So as you can see, it puts these individuals in 2 more distinct clusters, although they are still linked through MyRU. It puts them into 2 different clusters that are linked through whole genome sequencing. And this is a TB cases flowchart. So this goes from 2007, which was when our first case was identified, that was linked through MyRoot and whole genome sequencing, and it gives examples of how these individuals were then linked from an epidemiological point of view. We did have one case in Lothian that was a brother of one of these cases. And also, I don't know if you can see it, but at the bottom it talks about if they did attend and engage with screening, and if their screening was positive, and if they didn't attend. It also gives indications of whether they were friends, relatives, work colleagues or partners. So from my point of view, what is my role as a nurse within the health protection team, the health protection team from a TB point of view? My role is 50% of my time is dedicated to health protection, and 50% is split between TB and BBV. So it doesn't really leave an awful lot of time. However, my role is to interview cases at the time of their diagnosis. That's to establish any contacts that are required to go for screening. It's obviously my responsibility to hopefully build up a good relationship with these cases. I also get contacts phoning me as well when they're worried about screening, and it's alleviating and reassuring any concerns that they have. I also carry out a risk assessment at the time they are commencing treatment, and that's to look at any risk factors. So if I believe that if they have alcohol abuse, drug abuse, or there might be other reasons that might be difficult for them to engage. And from that, do they need to look at direct observed therapy, which would mean perhaps going along to a local pharmacy, or if we can maybe look at VOT, which is video observed therapy. That's something quite new. We have been doing it with a case recently. It's kind of worked out okay, and we're looking at different ways that we can implement that through the new near-me system. And we're hoping that the case that we're using at the minute will be able to assist us with that. We audit the number of cases and contacts, and we feed all that information back to Health Protection Scotland. That involves me completing ESME forms, which is enhanced surveillance of mycobacterial infection. And I obviously take part in any MDTs and cohort reviews. So examples of screening that we've recently undertaken: there was a huge homeless screening exercise that was carried out in Perth. That was actually my predecessor, Jo, that carried that out. I did help her with that, and it was huge. We've looked at colleges, universities, and we also jointly undertook a screening exercise in a public house in Dundee. That was very interesting, an exciting exercise to be part of. And for the future, part of the framework for Scotland includes looking at latent TB screening to identify these individuals, because we want to eradicate it. That is proven a bit difficult at the minute, but we have a small window of opportunity that I'm hoping that we can tap into. So we've identified one GP practice in Dundee that may be willing to look at that and identify people from high prevalence countries. I'll hand over to Danny.
Okay. Thanks, Margaret. So, as I said, I'm going to be very brief, and just to try and give you a bit of the context of the public health function in relation to TB and what the sort of underlying principles are and the themes that I think Margaret's expressed quite clearly and readily already. So we know that, first of all, the incidence of TB is on the rise in the UK over the last 20, 30 years. Partly that's to do with ageing populations, it's to do with inward migration and the background levels of health at different parts of society. In Scotland, we obviously see smaller numbers than in parts of England, but there are certain hotspots, Glasgow being one, and to a lesser extent Dundee and Tayside more widely. The determinants of who acquires and becomes unwell with TB are a lot to do with social circumstances as well as medical circumstances, and the two interact. And so our role is in trying to delineate and also work towards alleviating some of those upstream causes and risk factors. We focus on underserved populations, and there's a definition there which comes from the PHE strategy, which is closely mirrored in the Scottish framework. So our overall objectives are to, working in partnership with all the clinical services and other support services, is to try and reduce the transmission and the overall burden of disease in society. And that's through promoting awareness of TB, managing outbreaks, intervening to limit people's capacity to transmit infection, ensuring that healthcare systems and services are effective as they can be, facilitating early diagnosis, and supporting effective treatment so that people are cured in effect and so can't go on to infect others, and also minimising the emergence of drug resistance, which is obviously an increasing concern worldwide. We've got three broad strands of activity that we work to try and achieve that vision. First of all, awareness raising. So an example of that recently has been to have events both in the public house Margaret was talking about. That was part of the purpose there, but also having a World TB events going along to the Overgate Centre and universities to just raise general awareness, tell people about TB, let people know what to do if they think they or members of their family might have symptoms, about how to access assessment and care. We also obviously vaccinate individuals who are at increased risk. That's a crucial part of the public health function, supporting paediatrics and others to identify those who are at increased risk, particularly children of parents who've either got time spent in or who were born in parts of the world where prevalence is higher. And then influencing social policy ultimately, so that the risk factors at an upstream level, thinking in terms of housing, overcrowding, barriers to healthcare, deprivation, which all go hand in hand with TB disease, to try and tackle those. We also support case management. Margaret's talked a lot around that, so establishing a rapport with the patient, helping them through any difficulties in their wider social situation which might impinge on their ability to maintain the regime of taking several tablets several times a day for 6 months or more. Part of that is observation of therapy, whether direct or video-based, and also when it comes to it, if we have to, we can utilise powers under the Public Health Act to either restrict people's activities, stop them going to work if that's a concern about transmission, and up to the level of potentially detaining or quarantining people to prevent the risk of spread, particularly where they're not adhering to treatment in the way that we would need to see. So that's all focused on individual cases, but we also have the role of case finding through contact tracing, following up people who've been exposed to TB, offering screening in a targeted way. Margaret's talked about new entrant screening, which is an area for development, and also supporting the surveillance function at national level, reporting in so that we can track trends, and Dave's shown you some of the data that comes through that system. So there's a whole wealth of activity which goes on all the time. It's a small part of the overall public health function, but it's one we're keen to continue focusing on, and it fits a lot of the wider public health ethos of tackling inequalities, supporting improvement of the position in terms of social determinants of ill health across the region and Scotland as a whole. So a couple of key references for us, and then back to Dave, our compare. Thank you.
Thanks, Danny. So I'm just going to ask Nick to talk about a case in a second, but just to lead into that, we talked about people who get TB or people who've been in close contact with TB. It's also affected by age, so if you're a young person, you're much more likely to get TB in your 20s and 30s. Very young children are likely to get TB, and also the elderly when their immune system becomes more senescent. But the large burden of disease is people of working age, which is of relevance because then, of course, it means that they're unable to work and provide for their families. Another big group of people who get TB are people who are born in other countries. So about 60 to 70% of all the cases of TB are from people who are born abroad. And the majority of those people don't come to this country with active TB. They come with latent or dormant TB, and then something about their emigration from a high-incidence country to a low-incidence country like Scotland means that TB wakes up. We don't know why. Countries which we see a lot of people coming from are countries where we've had historic links. So we see a lot of people coming from the Indian subcontinent, And in India, as you can see, there's a huge big ball of cases. And many of those cases in India have problems with drug resistance due to less than ideal antibiotic stewardship, anti-TB drug stewardship in India over the last 20 or 30 years. So one of the things we've done in the MDT over the last 18 months is a very complex case management that Nick's going to tell us about.
Thanks, Dave. So anybody who's come to the ID unit in the last 18 months will know this lady, and I've spent countless hours with her and her partner over the last 18 months to run through things of which are a very complicated case in a succinct manner. I'll just briefly run through the background. 29-year-old lady, Pakistani, born and bred, emigrated to the UK about 2.5-3 years ago, and she was initially seen actually in haematology outpatients with what was suspected to be lymphoproliferative disease. She had large swelling in the neck, night sweats and weight loss, and she had cross-sectional imaging demonstrating quite necrotic-looking adenopathy in the left cervical region and the mediastinum, but also had some vocal cord and laryngeal thickening and some inflammatory changes with cavitation within the right middle lobe. She had a biopsy undertaken, an excisional biopsy by ENT, and unfortunately there was no tissue sent from microbiological culture at that time, and all it showed was granulomatous lymphadenitis, which obviously would raise the suspicion about tuberculosis. Subsequent aspirate from a kind of cold fluctuant abscess in the neck yielded Mycobacterium tuberculosis, and she was commenced on standard treatment as we would do for a patient with whom we thought we have a new diagnosis of TB, and that is pending further tests which will give us additional information about drug susceptibility. And these are done on a molecular level, so looking at genes that confer resistance. These tests normally take about a week or so to come back, and so she was started on treatment, and the results came back and initially caused a bit of alarm from the Mycobacterium Reference Laboratory in Edinburgh, where she had quite marked genetic mutations that would confer resistance to quite a wide range of anti-tuberculous therapy. So first-line drugs like rifampicin and isoniazid, there were genetic mutations consistent with resistance to these agents, along with genetic mutations consistent with resistance to ethambutol, and also fluoroquinolones, which are a highly useful group of agents, second-line agents in drug-resistant tuberculosis. At this point, because the patient's treatment was likely ineffective, she was called, we told her to stop her treatment, and an admission was arranged at that point to kind of commence her on essentially drug-resistant TB treatment. And those results were confirmed by actual phenotypic drug susceptibility testing when they test the actual TB isolate to the drug. So these were just genetic tests suggestive of drug resistance, but the tests where they look and see if the bugs are affected by antibiotics confirm these results. Multi-drug resistant tuberculosis is defined by the presence of resistance to both rifampicin and isoniazid, so two kind of the core, the most important anti-tuberculous drugs. And rifampicin-resistant TB is essentially often considered in the same umbrella because it is the drug that you want to be susceptible to if you have tuberculosis. There may be some additional resistance present, so resistance to second-line agents, fluoroquinolones or injectable agents, most of which are aminoglycosides. If you have resistance to one or both of these classes of drugs, you have what is known as pre-XDR or XDR resistant TB, respectively. And MDR TB treatment is complicated. So the available drugs are less effective, they're poor. Treatment failure and mortality is much more common. WHO data suggests that probably less than 60% of people with MDR TB are treated successfully, so the outcomes are actually pretty bad. There's significantly more drug-related toxicity. So drugs are quite toxic, difficult to tolerate, and that is one of the reasons why patients are more likely to fail treatment, because they're probably going to stop taking drugs just as a result of adverse effects. And generally the course of treatment is prolonged, at least 18 months, but often 20 to 24 months for the majority of patients with multi-drug resistant tuberculosis. There is recent data from the STREAM trial, which has been approved as a kind of shorter regimen by the WHO. It was initially tested in Bangladesh, and there is a shorter regimen which is similar to, in outcomes, to the kind of conventional longer courses of treatment, but it has to be used in very specific circumstances, and that, even then, is for 9 to 12 months. And that was the kind of state of play a few years ago in terms of multi-drug resistant tuberculosis treatment. So essentially you chose a fluoroquinolone, you chose an injectable agent, normally aminoglycosides, which have significant nephro and ototoxicity, and then you pick a bunch of other drugs which have quite significant toxicity. Cycloserine and linezolid in particular are very, very difficult for patients to tolerate, and you try to create at least a 4-drug regimen, ideally, as a minimum, with some additional agents that you may add in as a kind of additional support for the regimen, because we know that tuberculosis evolves resistance when single or few drugs are given, and that's why a kind of broad range of drugs have to be given to, if you like, reduce the risk of evolution of resistance on treatment. She was admitted in May last year. She was isolated. She was commenced on this highly complex drug regimen, essentially involving 6 active drugs initially, and pyridoxine was used to counter the neurological toxicity of both prothionamide and cycloserine. And drug monitoring and adjustment was performed mainly to tweak the doses of amikacin and cycloserine. And after 4 weeks in hospital, she was sent home with very close follow-up with our OPAT nurses who monitor the injectable component of her treatment, the PIC line that she had, and under very careful observation of therapy under the health protection team, who she was sending videos in daily of her taking her treatment. Numerous issues arose as a result of drug toxicity. She developed anemia as a result of myelosuppression from linezolid, and the dose was reduced and then subsequently re-escalated. She had severe depression and social isolation. Some of that was due to being at home on her own and the stigma of having tuberculosis, and some of it, without doubt, was related to cycloserine, in which 3 out of 4 patients have neuropsychiatric effects, including depression and psychosis. There was limited engagement with psychology, but we did try to kind of explore those avenues to support the patient. She had intractable vomiting despite antiemetics, and that was likely due to the prothionamide, which was subsequently discontinued with resolution of the vomiting. And in October, so this is now about 5 months in, she started complaining of tinnitus, which was a concern from our perspective because we were worried about the prolonged aminoglycoside use in rendering what is essentially a young woman deaf. So at that point, we were looking at the agents that we had available to us, and really we're down into this kind of fairly grim kind of, what was this kind of grim and kind of evidence-free zone almost at that point of drugs, 2 new TB drugs which had relatively limited evidence. They were associated with QT prolongation, but there was little alternative, and we made an application to the National British Thoracic Society MDR TB panel for use of bedaquiline. They agreed that it would be a worthwhile venture, and we closely monitored her QT interval with introduction of this and discontinued her amikacin at that time. QT, unsurprisingly, did rise on commencement of bedaquiline, which is a known side effect, but it never rose to the threshold of 500 milliseconds, at which we kind of start panicking. She had further issues with development of peripheral neuropathy, and despite the dose of pyridoxine being increased and gabapentin being commenced for neuropathic pain, and she really was completely debilitated with sensory neuropathy as a result of linezolid, so it had to be discontinued at that point. And bearing in mind, most patients that receive linezolid, there's a strict 4-week, if you like, cap on the duration of treatment, but in MDR TB patients we often use it for 6 months or even longer if we can. It depends on how well the patient tolerates the drug. The peripheral neuropathy progressed further, and cycloserine can also cause peripheral neuropathy, so at that point we discontinued cycloserine. I think it made sure there were no other reversible causes to her peripheral neuropathy, and we added a drug really from the 1950s para-aminosalicylic acid, essentially an aspirin derivative with very, very poor anti-tubercular activity, which she tolerated dreadfully. And at that point, our backs were really up against the wall, and there was a discussion about using this additional new anti-TB drug to kind of maintain sufficient number of drugs in her drug regimen and prevent the development of resistance on treatment. There was a discussion with the National MDR-TB panel, and they felt that it would be off-label compassionate use, and they suggested reintroducing cycloserine if she really wasn't tolerating the aminosalicylic acid. I was reluctant to do that, but the panel did also say they would consider using delamanid, which is this new anti-TB drug. The evidence base is extremely limited, so there's very, very few patients on which there is data on receiving both drugs, and there are concerns about QT prolongation and sudden cardiac death as a result of polymorphic VT. There was a recent cohort of patients with MDR-TB from the MSF group, with only 28 patients who had received both, and these were highly drug-resistant TB patients, and it seemed to suggest that the combination was safe and relatively effective in patients who are extremely difficult to treat. So these are the new kind of 2018 kind of order of drug selection for MDR-TB, and you can see that bedaquiline, which was once regarded quite far down the list, is now very, very high up the list, and that's because of evidence suggesting it is actually a very efficacious drug. And really, she's on these 4 drugs here, and then this other alternative, delamanid, is an additional agent here. So it's kind of moved up a wee bit in terms of the hierarchy of MDR-TB treatment. So she still was having profuse diarrhoea despite loperamide. She was struggling to tolerate the para-aminosalicylic acid, and she was definitely unkeen to take cycloserine again because it made her depressed and probably was contributing to a peripheral neuropathy. So following discussion and counselling the patient about the risks of QT prolongation, she accepted the risks, and we made the switch after we could obtain a supply of the drug, which had to be ordered in from October, from Germany. I think Kirstine had to make numerous phone calls about that. And she had fortnightly ECGs conducted for the first 3 months on combination treatment and remained stable throughout. So that really is, the green box indicate the drugs that she's on, and the red lines indicate drugs that she's either resistant to or she's failed to tolerate, and that is the entire MDR-TB armamentarium. So she's essentially exhausted all drugs, and so our backs really were up against the wall. And she continues on this regimen of 4 drugs, and the plan is to complete treatment probably early next year, and that hopefully will be her done and dusted. Thoughts from that case, from my perspective, certainly it highlights that despite being in a well-resourced setting, there really are significant difficulties with MDR treatment in supporting patients getting through, the monitoring and observation that's required, engagement with public health and other colleagues. The patient engagement is crucial, and again, the sourcing of complex drugs is actually very difficult, and we had real issues sourcing both of these new TB drugs, which were being used for the first time in Scotland. Right, I'll pass you back to Dave.
I think that's where we'll actually leave it. So just to say at the end, where are we with TB and Tayside? What we've, I think, shown you is that although the cases that we've had compared to the 1950s are much reduced, our ability to get rid of TB is levelling out now, and this is in part because we're treating patients who have got severe social problems, major problems with drug resistance and so on. But what we're going to try and do is with the MDT is try and drive that down so we could reach elimination over the next 15 or 20 years. A couple of other things we've done recently is set up a new pathway for people in biologic therapies done by Morven Wilkie, our registrar in Perth, where anyone getting anti-TNF drug or a similar drug which is associated with TB is now going to be screened. And as Margaret says, we're trying to set up a TB screening pathway in primary care for new entrants. I just want to say thank you to other members of the MDT. So Busi Muka is one of the other ID physicians, and Lynn Urquhart and Jorge Rojas as well, who's joined us more recently. Nick Connolly is a paediatrician who sits in the MDT, and also everyone from microbiology led by Will Olver. Thanks very much. not much time for
I
questions.
don't think there's really much time for questions because we're already at 2 o'clock. The Perth thing is timed out, so we're all done and dusted. I think you'll probably hang around for 2 minutes if anyone's got any questions that they specifically wants to ask to Dave. Thanks very much. Without further ado, next week pharmacy is back, but they're back by themselves. And I advertised it was Kirsten, but it's not. It's Heather. Apologies to Heather. And Heather's going to come and talk about antimicrobial prescribing. Apologies to Perth. I cut you off because I thought there was no one there. Turns out there were loads of people there, just hiding in the shadows. So hopefully they don't feel too hard done by. Thanks very much. See you next week.